Acha, so the topic given to me was novel and innovative therapy to treat hyperlipidemia, and I was correctly placed after Abdul Aziz Saab, for the Aziz Saab, because he was supposed to give everybody a very good general overview, which he did. We have talked about statins and fibrates and everything, and but all of us in clinical practice have seen patients who are intolerant of statins. Yeah, they are not really achieving the target levels of LDL with maximum tolerated statin therapy. This has already been discussed, like cardiovascular disease is the commonest cause. Acha, वैसे we quote cardiovascular disease as the commonest cause. WHO's 2019 report for Pakistan actually said that in Pakistan the commonest cause of death is hypertension, and it has surpassed cardiovascular disease as the commonest cause of death. Anyway, still 18.6 million people die of cardiovascular disease every year. We know all this, but probably the most astonishing fact is that in the last 1 minute, 34 people have died just because of the complication of coronary artery disease. So this is something that is probably killing the mankind more robustly than anything else that we know of, and obviously we need to do our best to avoid it. Uh, what we know is that people who are at risk of cardiovascular disease, their LDL levels have to be below a certain level. So this threshold was 130 a good few years ago. Then it changed to 100, and now we know people at risk, their LDL level should be 70 or below that. What we also know from all the US-based studies, and also ENHANCE, which encompasses some of UK data as well, that people who on maximum tolerated doses of statins that are being seen in our daily practice, only 20% roughly of them achieve their LDL targets, and 80% of them do not. And I think this applies to Pakistani population as well, where the first thing that they leave after a heart attack is likely to be a statin, because all the know-how that they think they have about the side effects of it. So statins are not really considered something tolerable in our population for sure. Um, we obviously need something against it. So I was gonna talk a bit about inclisiran's mechanism, because obviously it's a novel thing. People are inquisitive. Even I was, when I was told to give this talk, to see how does this actually work. Just briefly, for people who are as unaware of this as I was up till a few days ago, the way statins work is that HMG CoA is the basic component or starting structure of cholesterol, and HMG CoA reductase is the one which changes it to melanolic acid, which becomes cholesterol later on. And with these statins, which are HMG CoA reductase inhibitors, we stop the production of LDL cholesterol there. Obviously, that has led to very successful reduction of cholesterol in a lot of people, but obviously there is a cohort of people where this mechanism alone is not really sufficient. So what does the new molecule inclisiran do? So what this molecule is, and so you have to bear with me, and then I'll show you a video how this works. The excessive LDL that is produced gets secreted into your blood. It combines with cholesterol and becomes LDL-C. This LDL-C has to be transported out of the body, the excessive LDL-C, via liver. So there are these receptors that come up on the liver, which are called LDL-C receptors. Once an LDL-C molecule combines with it, they switch down, they turn around, and they go back into the liver and release that LDL molecule into the liver, through which it goes out into the bile. Each LDL molecule under normal circumstances can do this about 150 times. 150 times it can come up on the surface, combine with the LDL molecule, take it back into the liver and release it out. The enzyme responsible for degrading these receptors is called inclisiran. This particular enzyme produces this DNA combination therapy, where the RNA which is formed to produce this enzyme, the inclisiran enzyme, this essentially degrades these LDL receptors. So they found a way of cutting off the supply of these degrading enzyme, and because these LDL receptors do not get degraded, so a higher proportion of them on the liver surface mean a higher amount of LDL can be taken off from blood, put back into the liver, from which it can be excreted out. Can we show this video? Video.
Elevated low-density lipoprotein cholesterol, or LDLC, is the most readily modifiable risk factor for atherosclerotic cardiovascular disease. LDLC concentrations are regulated through the expression and action of LDL receptors on the hepatocyte cell surface. The number of LDL receptors can be reduced by certain mechanisms, including through the action of the proprotein convertase subtilisin kexin type 9, or PCSK9 protein. Specifically, the PCSK9 protein binds to and promotes the degradation of LDL receptors. Fewer LDL receptors on the hepatocyte cell surface result in elevated circulating LDLC. PCSK9 protein production and action can be interrupted by targeting PCSK9 messenger RNA, or mRNA. This process is naturally occurring in cells and is called RNA interference. RNA interference has been harnessed to develop protein-specific therapies called small interfering RNAs, or siRNAs. Inclisiran is the first and only LDLC-lowering siRNA therapy. Inclisiran consists of two strands, the sense strand and the antisense strand. This duplex, along with other chemical modifications, enhances stability and maximizes inclisiran's bioavailability in the liver. Further, the sense strand is attached to a molecule called N-acetylgalactosamine, or GalNAc. GalNAc binds to a highly expressed receptor on the hepatocyte cell surface, allowing for rapid uptake of inclisiran and resulting in undetectable plasma concentrations within 24 to 48 hours. After its hepatic uptake, inclisiran enters the cell by endocytosis, protected within a membrane-bound vesicle. GalNAc is degraded, and the duplex is slowly released over time into the cytoplasm. Inclisiran then binds to machinery called the RNA-induced silencing complex, or RISC. The RISC requires only the antisense strand and is directed to identify and bind PCSK9 mRNA within the cytoplasm. One RISC can cleave multiple copies of PCSK9 mRNA, thereby preventing the production of the PCSK9 protein. In summary, if left unmitigated, PCSK9 reduces the LDL receptor number, which limits the removal of circulating LDLC. Inclisiran interrupts PCSK9 protein production and action, which ultimately decreases circulating LDLC.
Okay, next slide, please. Okay. So these are some of the pharmacodynamics. Obviously, it's a new molecule. But I think for most of us, a couple of things that we really need to know is how quickly will the LDL start coming down. It's about 14 days. Essentially, 14 days to a month is roughly what we expect with statin as well. It absorbs pretty well after sub-Q administration. The dosing is in a way that the first time a patient is being given this dose, the second subsequent dose will be in 3 months, and then after that they will be given this injection, which is sub-Q injection, every 6 months. So essentially in the first year you'll get, a patient will get 3 doses, and then every subsequent year they will be getting 2 doses a year subcutaneously. It comes in a pre-filled syringe, so we have given it to a couple of patients before DRAB approval out of compassionate use. They were really young kids who have already had a cabbage, and still the LDLs on 80 milligram of atorvastatin was sky high. So we had to ask the company to bring it, which they gave for free to a couple of these patients, and they responded pretty reasonably well. So this is just maintenance doses thing, which we have spoken about. Sustained duration, the way they have made it sustained is that they have protected it from degradation from other hepatic enzymes by a second molecule that combines with it and makes it durable, and the effect lasts for over 180 days. So we know by this mechanism theoretically it does reduce your LDL cholesterol, but where is the safety data and what's the long-term data? So we don't have a lot in terms of long-term data, but we have good few trials which sort of gave us a bit of medium-term data, and that is 18 months. So these were all grouped into phase 1 trials, phase 2 trials, and then the phase 3 trials. So we are going to primarily talk about the phase 3 trials that came out. In these phase 3 trials, they sort of targeted various subjects. In Orion 9, they targeted familial heterozygous hyperlipidemias. Orion 10, they targeted patients with developed atherosclerotic heart disease or cardiovascular disease, which included either heart disease, vascular disease, or peripheral arterial disease. All of them, if you look at the LDL levels, they look pretty reasonable from our standards. Even the one with the highest LDL was 100 or more was the criteria, but they became more strict with patients who had developed atherosclerotic disease, and they targeted an LDL of more than 70 as patients suitable for this. Remember, targeting such a tight line means you have to show a lot more benefit than you would expect in somebody where you're starting off with an LDL of 200, because it's much easier to show benefits there. So that's what they picked up. And then, in Orion 11, they picked up patients with ASCVD risk equivalents like diabetes and 10-year risk more than 20%, and there they were a bit more stringent about things. Because, so they combined all these 3 trials data for REs probably. So all of these patients were more than 18 years of age. So they were not taken off statin. They were supposed to remain on maximum tolerated doses of statin, and they were supposed to have an LDL more than 70 in 2 of these and more than 100 in 1 of them. And then the exclusion criteria was that them having NYHA class 4 and stuff, obviously because we don't know if it would do any harm to these patients. So efficacy endpoint was LDL reduction versus a placebo, and secondary endpoint was LDL change over time and changes in PCSK9 levels in the body over time, and what are the other lipids doing with it, like non-HDL ones. Primary endpoint, as I said, they also use these sequential testing procedures where patients were not only checked at pre-specified intervals, but they were also averaging their LDL levels to make sure that it's not just LDL reduction at those specific endpoints, but also an average was taken for their cholesterol reduction throughout these days. Like this visit at 150, but there was also a visit at 90 days to check their lipid levels when they were coming in for their injection. So pretty robust. They screened about 5,000 patients, randomized about 3,500, half of them to placebo and half of them to inclisiran, and further halving them into safety data and intention to treat data. Almost more than 90% of these patients completed the trial. If you look at it, age was 65 years was average, and male gender was around 68. So 2:1 was for males to females. And diabetes and all the usual risk factors that you would consider in baseline were equally distributed. So what we saw was a 55% reduction in their LDL levels in patients who underwent treatment with inclisiran on top of their maximal tolerated statin doses versus 0 to 2% decrease with the placebo. They did this time average analysis as well, where they calculated patient average years. So they were able to multiply this data to 9,000 patient years, and they showed a consistent performance across all these years, just so that they can prove that based on this 18-month data, we can predict a longer term data as well based on their safety data. So we'll skip this in interest of time. This is probably the most widely quoted slide. Anywhere you'll go and talk about inclisiran, or if you want to see any talk on in ESC or ACC, this is what they'll quote to you. So the serum PCSK9 levels that they checked was reduced by 83% over 6 months. Total cholesterol was reduced by 32%, but the most important finding, which nobody's really talking about it, is the LP little a levels. This is the only therapy along with the other PCSK9 inhibitors which has shown to reduce LP little a levels by almost 20%. None of the statins have shown it. None of the any other oral anti-lipid drugs have shown this. And then almost 50% reduction in your non-HDL cholesterol, which is your total bad cholesterol level. So they were able to average it out and show it over 1.5 years across all the spectrum, your PCSK9 levels in the body, which is the enzyme which is degrading your LDL levels. The total cholesterol has gone down, LDL-C levels have gone down, and apoprotein B levels have gone down. In terms of achieving your target thresholds, they were able to achieve this across the spectrum in about 30 to 50% of patients. If you look at it based on sex, age, diabetes, race, they were able to show a significant reduction even in patients who were already on maximum tolerated statin doses. So what's the efficacy? There are 2 doses of treated that are given. It provides a sustained lowering of LDL, we have seen it, and this decrease in LDL was seen across all these pre-specified groups. In terms of safety data, pretty safe. I think I'll just show you what they have shown just so that you are aware of these questions which will come to you if you prescribe this. So they have looked at TEAEs, treatment emergent adverse events, and then serious ones were called TESAE, and these were reported if they led to discontinuation of the drug. So essentially, majority of what we saw was nasopharyngitis. So if you look at any of the data present right now or any of these talks that are given in ACC and ESC in the last year or so, they are all just talking about nasopharyngitis, and the incidence of this mild upper respiratory tract infection was very similar to your placebo group. But because patients were being given it, it has made it to their the booklet that comes with it. So patients are going to ask you about it. It's very similar. The only difference between the two was at the protocol-defined injection site, where there was a tendency of slight swelling, and even there, in all their trials that they have mentioned it, they said it did not last 6 months, it lasted a few days. So it's not something that your patient needs to be worried about, that because this drug is being given for 6 monthly basis, the side effect will remain like that. So those are the 2 main ones, the upper respiratory tract infections, which were reported, but they were equal in both groups, and then the injection site reaction, which was seen in 5%, mild itching, erythema, and swelling. Across everything else, liver functions, kidney function, everything remained the same. 16% of this drug is excreted through the kidneys, which is very similar to what rosuvastatin does. Atorvastatin and other statins are around 1% excretion through kidneys. I'll just quickly skip through this. So we saw 55% reduction in actual observed values for LDL-C. Safety and tolerability was very well proven. And then they are still following these patients for longer term data. In summary, how we approach cardiovascular disease and atherosclerotic disease today can change the future for millions of people. Inclisiran is the first and only approved siRNA. We saw the mechanism. It's a strong complement to maximally tolerated statin. It is not to be given in somebody who has not even tried a statin. They should be ideally on some dose of statin. In US, it was very hard to prescribe it at the start. We only had Rapatha, but you had to prove that the patient was tried on at least 2 statins before we went to this. So because statin has proven long-term data, this one doesn't. So it will definitely provide us with that data in the coming years, because there's nothing wrong that is showing up or signal-wise. But until then, we should at least keep some degree of statin on board. Thank you.